thank you for joining us today for this wee chat on Ehlers-Danlos Syndrome and hypermobility disorders, which we'll be covering in the next hour. So what we're going to be doing today is talking about, thanks for coming, that's really good, and we'll be talking about some definitions when we're covering Ehlers-Danlos and HSD. We'll find out what some of the terms are that are commonly used. We'll just spend a wee bit of time talking about EDS and HSD. We'll talk about how diagnosis is done, and just a wee chat about children and EDS as well. And then I hope to spend most of our time today talking about management. And then at the end, we have just a wee section on some links for supports for people who want to find out more about EDS and HSD. So just to sort of reiterate that today's talk is really an overview. We only have an hour to sort of touch on everything. So it's just really an overview about EDS and hypermobility. And the other disclaimer I want to say is that I'm not an expert on EDS. I have an interest in it because we come across it quite a bit in our work here at MECFS Canterbury, but I'm definitely not an expert. And, for that sort of expert opinion, you'd have to go to your doctor or a medical person to get confirmation. And just before we move on, I just want to talk a wee bit about the zebra, because the zebra is the international symbol for Ehlers-Danlos around the world. And they chose this for a few interesting reasons. I really like the way it's used, actually. The first reason is that when doctors do their training, apparently, one of the things they're told is when you hear hoofbeats, don't look for zebras. And what they mean is when you're investigating something, look for the common, look for the usual, not for the unexpected. Whereas with Ehlers-Danlos and hypermobility spectrum disorders, they are the zebra. They are the unexpected or the unusual. And so when you're investigating EDS, you do look for zebras. And the other thing about zebras is that every zebra has its own stripe pattern. They're all unique, a little bit like our fingerprints. And that sort of really represents the experience that people with EDS and HSD have with their illness, with their condition. It is unique to everybody. And last of all, does anyone, well, I don't know if anyone knows this, which I certainly didn't, is that a group of zebras is called not a herd, not a flock. A group of zebras is called a dazzle, which I think is a lovely word. And in the sort of statement that Ehlers-Danlos put out about their organisation, they say that living with EDS or HSD is not always easy. We take comfort and pride in the strength and support of our community and what we can achieve together. And together we dazzle. So I think that's a really lovely symbol, and says a lot about the organisation and people who have this condition. I'm having a bit of trouble moving along here for some reason. Not sure why. Oh, here we are. Okay, so here's our quiz. So if you can get your pen and pencil or have your phone ready, and it's just 8 or 9 questions, true or false. If you just want to jot them down, the answers, and if you don't know, just have a guess. That's absolutely fine. So Ehlers-Danlos syndromes are all about stretchy skin. True or false? EDS and HSD are conditions that are really just, it's about being bendy, super bendy. True or false? Hypermobile EDS, hEDS, is more severe than hypermobility spectrum disorder, which is what we call HSD. Number 4, hypermobile EDS is diagnosed by genetic testing, true or false? Number 5, there's no treatment for EDS or HSD. Number 6, EDS and HSD don't cause pain. They're painless conditions. Number 7, EDS and HSD can be treated with collagen supplements. True or false? And number 8, you can be too old or too young to have EDS or HSD. It's an age-specific condition. True or false? All right, well, we will revisit this little quiz at the end, and we won't mark them publicly, but you can have a wee look and see how you did on the quiz. Right, so let's just start with a few definitions. So first of all, we're talking about joint hypermobility. And really, hypermobility is just the ability to bend or extend the joints past the normal optimal range. So your joints extend past what would normally be considered, well, what would be considered normal. It's present in both EDS and HSD, and people who have this ability in the past were called double jointed. Of course, there's no such thing, but that was what people used to explain the condition. And about 1 in 5 adults actually have some degree of hypermobility. And in itself, it's not a problem. It can actually be an advantage in certain sports, like if you're a gymnast or a ballet dancer or a swimmer. And those of you who remember Michael Phelps, the Olympic swimmer, if you'd ever seen him warming up, his warm-up exercises really demonstrated a degree of hypermobility. So it only becomes a problem when the joints become unstable and put too much strain on other body parts. And at this point, they can cause joint subluxation, which is like a partial dislocation and sprains. And we start talking about joint hypermobility because this is often the most obvious feature in both EDS and HSD, and diagnosis often starts, or people start to look for this diagnosis because they have hypermobility. And what's the difference between hypermobility and flexibility? Because you may consider that hypermobile people are very flexible, but there is actually a difference. And hypermobility is about joints. It's about the joints and ligaments not being supported and over bending, whereas flexibility is talking about muscle stretching. And someone who's very flexible and who does a lot of work on muscle stretching and flexibility can actually at some point put some strain on their joints and may actually start to look a little bit like hypermobile, but in themselves they are different things. So someone who's very, very flexible is not necessarily hypermobile. And the thing about hypermobility, EDS and HSD, is that these are connective tissue disorders. Connective tissue is the kind of tissue that holds our body together. It's material that's found all through our body and all our different organ systems. And so problems, therefore, with our connective tissue can create problems in different parts of the body that at first glance may not be related. So connective tissue provides strength in our ligaments and tendons. It creates flexibility in our blood vessels. It's present in a lot of sort of the body functions. So for example, when oxygen and nutrients pass from capillaries to cells, that's connective tissue is involved in that process. And various parts of the body are specialised, are full of connective tissue, for example, the cornea in the eye. So when you have connective tissue disorders, they cause disruption to many, many processes throughout the body with lots of varying effects. And different parts of the body are affected so that people present with problems that may not be related. For example, some people have bowel problems, some people have orthostatic intolerance problems, and this inability to join the dots by the medical profession can often really cause lengthy delays in diagnosis. So now we move on to sort of thinking, what is EDS or Ehlers-Danlos Syndromes and hypermobility spectrum disorders? What's the difference? Well, Ehlers-Danlos syndromes are a group of about 13 syndromes. Some people say there's 14, and most of these are very rare. The most common is hypermobile EDS. About 80 to 90% of people have that kind of EDS, and that's the one that we'll be really talking about today. All of the EDS syndromes are thought to be inherited, and gene mutations have been found for all of them except hypermobile EDS, which is the most common. So therefore you can get genetic testing for all of them except the hypermobile EDS. Usually the kind of things that you're seeing in Ehlers-Danlos syndromes usually involve joint hypermobility and or skin hyperextensibility and or tissue fragility. And it affects men and women equally. It affects all ethnicities. It was thought originally to be very rare, but now they're looking at perhaps 1 in 2,000 people have EDS, and perhaps even more than that. It's just people are getting much better at recognising and diagnosing it. So hypermobility spectrum disorders are also connective tissue disorders, but people with the HSD do not meet the stringent diagnostic criteria that EDS have. So someone with hypermobility spectrum disorder, or HSD, has symptomatic joint hypermobility that can't be explained by other joint conditions. So you have joint instability and often have injuries and pain with it. Poor proprioception, which is that awareness of where you are in space. So if you see somebody who's very hypermobile, often they'll be standing in a relaxed position. If you look at them, their legs are kind of bowed backwards because their knees are sort of hyperextended. They'll often have their hands or upper limbs in strange positions, maybe very sway backed. They look uncomfortable, but they don't feel uncomfortable. They're not getting feedback from their bodies, from their joints, that their joints are in an abnormal position. HSD might just affect certain groups of joints. So with HSD, there are actually 4 subtypes. So you could have all of your joints affected. You could just have peripheral joints affected, like hands and feet. You could just have one joint or a group of joints around that joint affected. So there are sort of different subtypes within the HSD as well. And the thing about it is that we're not sure, or people are still not sure, whether EDS and HSD are the same thing, but on different points of the spectrum, or if they are really very separate, distinct conditions. The main difference appears to be at this point that EDS is genetically defined, or it's inheritable, whereas hypermobility is usually doesn't seem to be. The point about it is that they present in the same way. Hypermobile EDS and HSD present in the same way. They are the same kinds of issues with the diagnosis, and management and treatment are approached in the same way as well. So to all intents and purposes, they are the same thing. There's just a difference kind of in diagnostic criteria that sets them apart. So hypermobile EDS is believed, as I said, to be the most common connective tissue disorder. It's definitely the most common type of EDS. About 80 to 90% of people with EDS have this particular type. As I said earlier as well, it's the only type that doesn't have a gene connected to it yet, and it's defined by joint hypermobility with subluxation and dislocation, and also skin issues. So people with hypermobile EDS usually have very flexible skin, soft and stretchy skin, and problems of scarring, etc. The other symptoms that are associated with hypermobile EDS are the things that make the diagnosis start to get a bit difficult, and there seems, and then this is where I was talking about the overlapping or the dots not being able to be connected, because very often with hypermobile EDS you get chronic pain and terrible fatigue. You get dysautonomia, so you get the POTS or the orthostatic intolerance with the pounding heart when you stand up and dizziness and things like that. You get gastrointestinal issues. So you either get, because everything in the gut is slowed right down, you either get chronic constipation, bloating, terrible gas, or else you get the IBS kind of symptoms. Very often get temporomandibular joint issues. So I was talking to somebody yesterday who said the first thing that ever happened to them was suddenly their jaw dislocated for no reason that they could see, and that's how her diagnosis to hypermobile EDS, that was the beginning of that journey. And there's often dental crowding and things as well. Spinal problems, so scoliosis, and you can imagine if you've got loose ligaments trying to hold your spine together, that you get a lot of issues in there as well. Mast cell activation disorder, so this is like hyper allergic response. So people may have food allergies, medication allergies, terrible environmental issue, seasonal hay fever or asthma, things like that. And almost always, or very, very commonly, anxiety is associated with hypermobile EDS as well. Why that is, we're not quite sure. So just touching on two other kinds of EDS, just to talk about them, but just to let you know that they are there, but we won't spend time sort of on them. Quite a common one as well is classical EDS, and they have identified the gene for that. It's a type 5 collagen fault, and this one can be diagnosed by genetic testing. But the main symptom with classical EDS, the thing that's very distinctive, is skin issues. So the skin is smooth, it's velvety and soft. It could be, some people say doughy, it feels doughy to touch, highly elastic, bruises very easily. There's a lot of scarring, abnormal scarring. You can have what we call hemosiderin deposits on your shins and elbows, so that they look like bruises, but it's actually skin staining, and the wound healing is not good, and the scarring is very poor as well. So with classical, the skin is the major issue. There's usually joint hypermobility as well, and then you can get these other symptoms that associated with it as well. So you get like calcified hematomas over pressure points. Those are like hard well, they look like bruises, but they're not. They're sort of hard, crystallized bruising over pressure points, cysts on forearms and shins, the muscle tone's very poor. So in this kind of EDS, you might find that there's delayed motor development with children, and you can have a history of hernias and rectal prolapse, heart valve abnormalities, and also people have issue in pregnancy as well. The other reasonably common EDS and the most severe form of EDS is vascular EDS. So hypermobility is not so much a feature of this one. What it is that the blood vessels are very thin and the skin is very thin. So there's a tendency to bruise more easily, and often it's the bruising, the abnormal bruising is often the most common sign. And also the thin skin, so you can see through the skin often, you can see blood vessels underneath it on the chest and on the limbs as well. With vascular EDS, there's a risk of organ rupture, and also because of the fragile blood vessels, there's also risk of bleeding, bleeding issues as well. Talking a wee bit more about hypermobile EDS, the most common. And so hypermobile EDS is often kind of experienced differently at different times in your life. And in the first years of life, it's like the hypermobility, the party tricks, the contortions, the dislocations are the most prominent sort of feature usually of the condition. The pain is usually limited to lower limbs and often sort of passed off as growing pains. Children sort of get tired very, very easily. And the other thing that's often quite a feature is this voiding dysfunction, which means they're either in the toilet all the time or they go very rarely. They don't get the signals that they need to go, and they sort of hold on for far too long. As time goes by and sort of in the midlife years, they talk about the pain phase as being the big issue. So you're getting more sort of musculoskeletal pain. In women, there's often pelvic pain. There's often pelvic pain, and headaches start to become quite a feature as well. The fatigue really ramps up. You're getting quite disabling and profound fatigue. And this is when you often start to see the other symptoms like that we were talking about, the gut symptoms, the orthostatic intolerance, maybe the mast cell activation, those sorts of things start to come out more in midlife. And then in later life, because of kind of wear and tear and sort of accumulated injury, you're starting to see more of a stiffness phase with sort of less joint mobility and sort of a reduction in functionality. So when people in the health profession are sort of taking a history, if they come across someone who presents late in life, joint hypermobility may not be a feature, but it will have been in their past. So it's very important to take that into consideration. So having sort of talked a little bit about EDS in particular, hypermobile EDS, it's, there can be a really big overlap in symptoms between things like EDS and ME, and I'm sure a lot of you were sort of starting to see some of that stuff, the profound fatigue, the orthostatic symptoms, the gut issues, things like that. There's often a real overlap, and it can make things quite murky and sort of quite hard to sort of know what's going on. But generally speaking, post-exertional malaise is pretty is a hallmark symptom in ME and CFS, and hypermobility is more often seen in EDS, although not all forms of EDS won't always have that. And it's why it's important to have quite strict sort of diagnostic criteria, which is certainly in EDS, they have got quite strong criteria. So how do we make the diagnosis? Well, often the symptoms start to kind of get clear in teenage years. It's really hard sometimes to tell with children what's going on. It can be quite ambiguous what's happening with children. They can present really differently in terms of they often have neurodevelopmental stuff going on. So very commonly you'll see hyperactivity or inattention or dyspraxia or autism seem to be the big issues. There's often a big emotional overlay. They have anxiety or hypersensitivity. Often it's sort of non-specific kind of abdominal stuff and growing pains. So yeah, sleep and food issues. So with children, it can sometimes be really difficult to kind of pin down what's going on, and it kind of clarifies a bit as the children start to grow up. And then there's a time from the symptoms kind of becoming a problem, and then people thinking, I really need to know what's going on and get a diagnosis here. And this can take a couple of years for that process to happen. And then sadly, often it can be about, and this is sort of international studies show, it can be up to 10 years before people actually get a diagnosis. And a lot of that has got to do with the fact of healthcare practitioners just not recognising what's sort of going on and not being able to, as we talked about before, join the dots. But when a diagnosis is made, the sorts of areas that people will look at is family history, because, as we said, EDS is genetic. It's usually inherited. So the first thing that practitioners will do is find out, is there anyone in your immediate family who has similar symptoms or has been diagnosed with EDS or hypermobility? Then they will do the Beighton Score, which we'll talk about in a minute. And there's also a diagnostic criteria checklist, which is really quite comprehensive. And then there's this acronym called Just GAPE, which is kind of a checklist to make sure that you've looked at all areas that need to be signed off. So here's the Beighton Score. The scoring system is a score out of 9. And what it looks at is, first of all, the pinkies, the fifth finger in each hand. So with your hand flat, can the little finger be extended more than 90 degrees back off the surface of the table? So there's 1 point for each hand. The second is the thumbs. So 1 point for each hand, with the arm out flat, palm facing down. Can the thumb be pulled back to the forearm? And that's 1 for each side. The elbows, so with the arms twisted with the palms facing up, can you, is the bend more than 180 degrees, or is there a 10 degree hyperextension there? Knees, the same thing, 1 point for each leg. When someone's standing, does their leg bow out more than 180 degrees? And the last scoring point is for the spine. So with somebody bent over and their legs straight, can they put their palms flat on the floor? And that gives you a score of 9. And if you get 4 or more, then you test positive on the Beighton Score. Keeping in mind that when people do this test, doctors and physios, they have a little instrument called a goniometer, which actually measures the angle, the degree of flexibility or movement through that joint. So they're able to do it quite specifically. And then, sorry, can't seem to move. There we go. And then there's the diagnostic criteria checklist. And this is what people should be using to make the diagnosis. And there's 3 criteria. The first is about joint hypermobility. The second criterion covers skin or tissue abnormality, plus family history, plus pain. And then the last criterion basically make sure that there's nothing else going on. They check that there's no other diagnosis in there that could cover up the EDS. So, but that's a really quite significant, specific checklist. And people who present for diagnosis, if they don't meet all of those, but they have hypermobility, then would be classed as HSD or hypermobility spectrum disorder. And here we have some examples of sort of tissue abnormality that people are looking for. So the skin hyperextensibility is always, the test is done on the forearm, and you should be able to pull the skin more than 1.5 centimeters off the surface of the arm. And you'll see on the next picture what I was talking about, the hematomas, the bruise-like marks that develop on shins and elbows and forearms. And on the right-hand side of the screen, you'll see right in the right-hand bottom corner, you'll see that very thin skin. You can see the vessels, the blood vessels under the skin there, which is very typical of the vascular EDS. And last of all, just the GAPE diagnostic tool. So people use this as well for diagnosis, and just standing for joint and other soft tissues. So that's looking at hypermobility, extensible skin, stretchy skin, skin abnormalities, scarring, hernias, all of that sort of thing, dislocations would be in that first category. And then G for the gut issues, A, allergy, autoimmune, or atopy. So looking at all of the food, medication allergies, autoimmune illness. Does this person have rheumatoid arthritis or Crohn's or any of these sorts of things? And then atopy is things like asthma, eczema, hay fever, that kind of group of related conditions. P is postural symptoms. Do you have orthostatic issues? Do you get dizziness? Do you get your heart pounding when you're standing up? And E is exhaustion, which I think is a very good word for covering that absolutely profound fatigue that occurs with EDS often as well. And with children, you know, as I said, they're often a little bit difficult to kind of pinpoint what's going on. So severe tiredness could be present as concentration issues, inattention. The blood pressure issues could be the lightheaded, dizzy, sweating, fainting, headaches, difficulty concentrating, pain. And with children, the pain is often persistent. It's like background all the time, the background pain. And they often have difficulty kind of explaining it or isolating it. And it can be seen as like fidgeting, inability to sit still, you know, hard to concentrate. The gut and bladder issues could be about being in the toilet a lot or not using it much. Joint pain or weakness, and often these children are clumsy, they're walking into doorways, they look uncoordinated, they just, you know, not very good with spatial awareness, and they often have bruises or scars, which is sort of much more than normal with children. So they can be a little bit difficult to kind of pinpoint what's going on. I'll just mention this, I can't bring it up, so I'll just mention that there is this amazing resource for anybody who has children in school who they think might be hypermobile or have EDS. There's this wonderful free resource that's been developed by a British group of teachers. It's really fabulous for teachers to talk about strategies in the classroom, what to look for. There's a beautiful little video on there where a little boy's interviewed, and he says, well, he explains why he's different and how the condition affects him. But yeah, it's a really wonderful resource for teachers. So if anybody knows of children going to school, this would be a great resource to use for the staff at the school. So let's move on to management. And I talk about management because basically, like many chronic illnesses, there's no cure for EDS, and management has to be strategized. You basically, if you have EDS or HSD, you have to be your own project manager. Ideally, there's a team involved in your care, and people with EDS and HSD are usually the experts in their illness. They often know much more than the healthcare practitioners who they're involved with. So you have to have a bit of initiative, and goals and a management plan are a good place to sort of start. So the team that you might want to have around you, and for a lot of people, GP and a physio would be enough, and most people are managed very well in primary care. If you can get a specialist physiotherapist, even better, because they know of the strategies that are needed to look after joints. If you need a specialist, normally it would be a geneticist and or a rheumatologist. I'm not sure how easy or accessible geneticists are in our health system, but a rheumatologist would be the specialist of choice if you're having a lot of joint problems. If your pain is not managed very well, your GP can refer through to the pain team and a clinical psychologist or counsellor, not because this is a problem that's all in your mind, but because psychologists, counsellors can really help provide strategies to deal with chronic illness, and they can be really helpful in this field. Occupational therapist for equipment, if you need any equipment to help with managing daily living, and a dietitian is a must if you're having some of the related gut issues. So all the different management strategies. So there's no cure for EDS or HSD, but there is a lot of treatment available. And probably the most important is physical therapy. Like the joints have to be well supported with strong muscles or with other, in other ways to prevent sort of long-term damage. So some of the physical therapy would be graduated exercise, supports, posture awareness, manual therapy, and proprioception training. There's also a treatment called Sclerosant Prolotherapy, which we'll talk about, which is about strengthening ligaments. Surgery as a last resort. Pain management is really important and a multi-pronged approach. Pacing and energy management. Sleep hygiene, really, really important. And management of all these other issues that are going on, the orthostatic intolerance, mast cell activation syndrome, bowels, anxiety, and last of all, really important to get a good support group that understands you, understands your journey, and can help share strategies for management. So for physical therapy, exercise therapy has to be graduated. It must be, you must have slow progressive increases. So it's really important to get that individual assessment and an individual treatment plan, an appropriate assessment and an individual treatment plan. It's exercise that a good exercise program will help avoid the deconditioning, which can lead you into that sort of downward fatigue spiral, where you you decondition, so you get tired, so you do less, so you get more tired. It's that a really awful sort of downward spiral. And if you can avoid that, if you can manage and maintain a certain amount of muscle fitness, you get a better quality of life. Physical therapy improves the joint stability, and that's probably the most important sort of outcome that you're looking for. But it also improves pain. It also improves proprioception, so that you have your joints in a more normal resting state. It improves POTS. So if you have orthostatic intolerance, the best management strategy for that is exercise. And it needs to be a blend of aerobic, a bit of aerobic, so maybe exercising in water or cycling, with kind of strength, which is sort of Tai Chi, Pilates, which you're looking more at your balance and control. And Nordic pole walking is apparently supposed to be really good as well. So the kind of exercise that's appropriate is avoiding heavy lifting, avoiding sports that have sharp acceleration and frequent turns, and so which is most contact sports. So your exercise has to be low impact and low intensity. But as I said, it's really important to be individually assessed and have your own exercise program kind of outlined for you. So supports and taping and splints. There's a little bit of disagreement about this because a joint that is always supported will become weaker. And so if you're wearing a splint or a support or taping all of the time, you're not allowing your body to develop the muscle strength around it to support the joint appropriately. But on the other hand, if your knees dislocate when you get out of bed, or if you're, working your computer and your fingers are dislocating, that's no good either. So I think the consensus is that if you need support when your joints are under pressure, it's good to wear it then, but it's also good to give your joints a break from taping or splints or whatever. And certainly it can help with post-injury recovery. And if you're going to tape, you've got to be really, of course, careful with skin. The neoprene splints are a nice, light sort of support for your larger joints as well. And compression garments are important for, leg compression garments important for orthostatic symptoms or POTS and things like that. But they also can help with proprioception. So if you're not getting feedback from your joints and muscles, you can get feedback from your skin so that you know where your body is sitting in space. And again, with splints, ring splints are very common, best to be prescribed by a hand therapist. And of course, really good to wear good supportive, sensible shoes. And orthotics are often very important as well, just to keep your foot in a really good position. So podiatrist, again, would be part of that management team if you're having foot issues. Sclerosant Prolotherapy that I was talking about earlier. So this is a treatment offered, as far as I'm aware, mainly by Dr. Fraser Burling, who's a specialist in Auckland. He has a large EDS patient list, and he uses the same medication that's used for varicose vein treatment to scar and shrink varicose veins. He's been using it for many years with really good effect. So what it does is if you've got weakened or damaged joint ligaments and tendons, what he does is he injects I want to say stuff. He injects it into where the ligament joins to the bone, which inflames and causes scarring and building of new tissue. And the strength, it takes many treatments, but the strengthening that occurs can avoid the need for surgery, and it often reduces pain as well. There's been some amazing success stories with this. Dr. Fraser Burling, you can research him online. He's got YouTube videos up talking about what he offers. I know that I know people who have been to him and are very swear by, they absolutely, well, they say that he's an amazing doctor. And I have to say that he has a very long waiting list. I know it's over a year. I believe he does take patients from all over New Zealand. And there are videos that you can, as I said, you can go and research them on YouTube. So surgery is pretty much a last resort when there's sort of damage there that needs to be fixed. So I guess the best possible thing to do would be to try and avoid that with sensible exercise and support of your joints before it's required. But sometimes it can't be avoided, and it definitely may be necessary for people who have issues with craniocervical instability. Pain management, we could spend a whole hour talking about this. The best approach to pain management is to try as many things as possible for pain. You'll see that medication is really low on the list. It's important to try as many other things as you can. So there's heat. You get wearable heat pads, which are apparently really helpful. You can get the stick-on ones as well that last for several hours. Some people get a lot of benefit from cold or alternating heat and cold. TENS machines are amazing. They work by sort of putting a bit of electric current across the skin, and they, I guess, confuse the nerve endings so that the pain isn't felt as much. And they're really very cheap to buy online if you ever wanted to, surprisingly cheap actually, if you wanted to get one for yourself and try them. And a lot of people get a lot of great benefit from them. Sometimes manual therapy, like a gentle soft tissue massage or trigger point or myofascial release. And then there's the techniques like mindfulness, relaxation, imagery, breathing techniques. A lot of resources online to help you with this. There's apps, there's videos. Again, counsellors can also help with this, and many people get huge benefit from employing these techniques as well in their pain management. Trying to get as good a sleep as possible, however you can manage that. If you can sleep well, you can deal with a lot more pain and other things that come your way. Medication for pain, and last of all, if you find that your pain is just unbearable and it's just not working, you could ask your GP for a pain team referral for chronic pain. With EDS, as in ME and CFS, the energy management is a really big and important part of your management. The fatigue is just so disabling. And part of that managing your energy is learning pacing techniques. And stop, rest, pace is a really good sort of a mantra to sort of have, just to remind yourself of really good pacing techniques. So always try to do less than what you've got energy for. Try to have a bit of energy left at the end of your day. Stop your activity before you get symptomatic, or if you start to notice that things are ramping up a little bit, stop before things get worse. Resting, really important. Preemptive resting. If you've got something on, rest before you go, or rest at the end of an activity. And then breaking your activities down into manageable, short bursts is also really important as well. And pacing is something that has to be practiced, and over time, it does get easier. Again, we could spend a whole hour just talking about management of all the other things that come along with EDS. So just to cap, a quick recap, but orthostatic intolerance, make sure you're getting enough fluids, at least 2 litres a day. electrolytes with those. They help increase your blood volume and just help relieve some of that dizziness and heart pounding when you get up. Compression garments, really important part. And if you have quite severe symptoms, then you can get medication to help with that as well. Mast cell activation syndrome, antihistamines, and avoiding environmental allergens if you can, keeping your home, dust-free and, all of those things, avoiding carpets, things like that. Bowel issues, and depending on your severity, the dietitian inputs really can be really helpful, plus medication. Anxiety, again, mindfulness, relaxation, counselling, and good sleep hygiene. And if your sleep is severely dysfunctional, there is a sleep clinic that you can get referred to. Last of all, just talking about the support groups and how important it is to be connected with other people who have similar issues to yourself. And also these websites have some amazing information, and management strategies are really very, very helpful, very good. Loosely speaking is the New Zealand support group Facebook group. It's a closed group, a private group, and I think very, very helpful as well. And last of all, just the talking about the Hypermobility Clinic. So as far as I'm aware, and I'm not sure, it'd be interesting to hear if there are any other EDS specialists in our region, but Anita is a physiotherapist who runs this clinic. As far as I'm aware, she's the only specialist healthcare professional in Canterbury region for people with EDS or hypermobility. She has a really good web page. Have a look on her web page. And I do have to say that she has, again, a very long waiting list. We were talking the other day, someone said they'd been waiting 13 months to see her, but she does an amazing assessment. She looks at you holistically, looks at all parts of what's going on, and offers a great treatment plan as well. And she can help with applications for funding from WINS, and she's also had people get funding from StudyLink to go and see her. Right, that's it. So now I'm going to go back, and if you just want to pull your, where are we? If you want to pull your little test out, and we can just very quickly flick through the questions and see how many of these you got actually right. So the first one that we talked about was Ehlers-Danlos Syndromes are just stretchy skin. Well, as we've discussed, you know that there's a lot more to EDS than that. There's the joint hypermobility, dislocation, scoliosis, scarring, and other issues such as fatigue, GI, and autonomic dysfunction. EDS and HSD is just being a bit bendy. No, much more than that. But we do know that there are a lot of issues with joints when they're not only hypermobile, but also unstable. Number 3, hypermobile EDS is more severe than HSD. No, they're equally severe, and the management and treatment is exactly the same. Hypermobile EDS is diagnosed by genetic testing. It's the only EDS that they haven't found a gene for yet. There's no treatment for EDS or HSD. There's no cure, but there's lots of treatments. EDS and HSD don't cause pain. No, they can. It's been shown that more than 90% of people who go to their doctors complain about pain and fatigue with their EDS. Can be treated with collagen supplements? No. Yes, these are connective tissue disorders, but collagen supplements have not been shown to help in any way. What happens is that your body just digests the collagen. You don't actually, it doesn't do anything to the connective tissue in your own body. You can be too old or too young. You can have EDS and HSD across the lifespan. And as we have discussed, they do present a little bit differently at different ages, but you're born with these conditions and you're affected throughout your life with them. So I hope you got some of those right. And now I was just wondering if we've got time for any questions or discussions, Rose, if anyone wants to.
We got a question, if that's right.
Yeah, sure.
Yeah, I just wondered, where and how you go about to get that genetic testing for the classical EDS?
No, I don't. And that's the other thing. I'm not sure. I think it would have to be through your GP. It would have to be through your GP, and they would have to make that referral into the public system. But I don't know if that is available, or if, in fact, people have to go privately and pay privately for it. So it'd be nice to know if anybody else knew. We actually had someone at our meeting last year, a couple of weeks ago, who has got classical EDS. Her and her mother have both got it. I could possibly go back to her and ask her, but how would I get that information out? Rose, have you got any idea?
People can email if they're particularly interested, and we can email back.
Yeah.
I think if you do do a Google search for genetic testing EDS, you might find some. I'm aware of the Pharmacology Clinic. Anita recommended a client to contact them for genetic testing, but it's fairly expensive. The initial appointment was $500 or something, and then the genetic testing was on top of that.
Another place to go actually could be the Facebook page, the EDS Facebook page on Loosely Speaking. That could also be very helpful. Yeah. And I see that Nikki's just mentioned that she had prolotherapy with Fraser. It was helpful but temporary, and that his wait list is now over 4 years, so that's a bit depressing. I also know of somebody who's had the prolotherapy, and they found it they did actually get long-term benefit from it. She had a series of injections for her knees, and she found that it made a big difference. That's just one person that I'm aware of, yeah. If there's someone in Christchurch who does it, that would be great. If you could look into it and find out and let us know, that would be really helpful. Because, I think that'd be great. Right, thank you. Because that's the thing, is that's just what's here on the South Island. It just seems to be so limited. So, yeah. And I think a lot of it is word of mouth. It's just, getting on the support groups, just finding out what other people have done. And, definitely word of mouth, I think, is a good way to start investigating some of these things.